Hello everyone. Please let me know if I'm audible and visible and we can go ahead with the session. So today's session is a short session on corneal ulcer, which is like one of the must know topics as far as any exam is concerned. So this is what we will be covering today. And if you look at the questions in the recent NEET PG exam or in any other exam for that matter, that is if we look at INI CET exam or even FMG exam, the questions are largely clinical. So corneal ulcer is a very, very clinically oriented topic where you get case scenario based questions. We also get image based questions. All types of questions are possible from this particular topic, right? So before we proceed with the topic, there are a few things that I want to tell you. So if you are still not a part of our Plus platform, so do download the app and take up the Plus subscription. And for that, you can use my code. My code is Dr Sudha. Similarly, if you want to be a part of both Unacademy and Prep Ladder, then you can go for this iconic subscription. And for that also, you can use the same code, that is Dr Sudha. So we are having this unlock this a special feature which is available from the 17th to the 22nd, and these are the batches that are going ahead on our platform. So this batch, which has begun on the 21st of July, this is meant for students who are preparing for the INI CET 2022. So this is going to be done over, this is a rapid revision kind of a batch, and we will be covering all the important topics for INI CET, and the duration of the batch is just 4 hours a day. So this, and in case you miss the live classes, the option of recorded classes like always is available to you. So this is the INI CET batch, which is supposed to start from the 21st of July. So these are the educators who will be a part of this INI CET high yield revision batch. And we are also having this focus FMG batch, which is particularly catered to the FMG students. And this has started on the 11th of July and it will continue till December. So those of you who are preparing for the December FMG, this is a good opportunity for you. And here we are going to have a complete coverage of all the 19 subjects. And this is a NEET PG test and discussion batch, which is essentially a batch for those of you who are retaking the NEET PG exam. So we will be covering all the 19 subjects, but in an MCQ discussion format and a rapid revision format. So IBQs, PYQs, clinical questions, integrated topics, all this we will be covering, and along with that we will be having mock tests. So these are the different NEET PG subscriptions that are available for you. And as I said, to enroll for this, you can use my code, that is Dr Sudha. Right, and also being a part of the Plus platform, it entitles you to our question bank, which has around 25,000 clinical questions. So with that, let us start our topic for today. So what is the topic? Let me first start with this question. As I told you, most of the questions today are kind of clinical. So this is the kind of question that we can expect. That is, a patient is presenting to us with pain, redness and watering in the right eye. On examination, we are told that there is a large and dry necrotic ulcer with feathery margins. And there are two smaller lesions which are located beside the main ulcer. And we are asked what is the likely diagnosis. And the options that are given to us are bacterial ulcer, acanthamoeba keratitis, viral keratitis, or fungal corneal ulcer. Right now, I will not give you the answer to this question. We will first discuss the topic on corneal ulcers and then we will come back to this question. So let us see what is corneal ulcer or infective keratitis. The first thing we need to understand is what are the factors which predispose to the formation of a corneal ulcer. Now see, when we talk about corneal ulcers, you realize that infection of the conjunctiva, that's conjunctivitis, viral conjunctivitis, bacterial conjunctivitis, these things are pretty common. Many of us have experienced this in our lifetime, but thankfully corneal ulcers or corneal infections are not so common. Now, why is it that? Why is it like that? Why are corneal infections thankfully not so common? The reason is that the corneal epithelium is very resistant to penetration by microorganisms. So as long as your corneal epithelium is intact, a microorganism is not going to be able to penetrate inside. So this means that there has to be a breach of the corneal epithelium. So anything which causes a breach of the corneal epithelium is something which predisposes to the formation of a corneal ulcer, that is infective keratitis. So see, let's look at these conditions. For example, corneal abrasions, dry eye, misuse of contact lenses. So if you misuse contact lenses, you can create corneal abrasions, breach the epithelium, and this may predispose to the formation of ulcer. Then neurotrophic keratopathy, exposure keratopathy, that is chronic diseases of the cornea which damage the epithelium and do not allow the epithelium to grow back. Then if there is prolonged misuse of steroid or anesthetic eye drops. These are conditions which also damage the epithelium and they may also result in the formation of a corneal ulcer. So the basic point is that anything which breaches the integrity of the corneal epithelium can predispose to the formation of a corneal ulcer, that is infective keratitis. Then of course the general causes for all infections are conditions which cause immunosuppression, which may be like prolonged use of immunosuppressants, patients who have AIDS, uncontrolled diabetes, etc. So these are the predisposing factors to a corneal ulcer. Now today in this session, I will be discussing about two types of corneal ulcers, that is bacterial corneal ulcers and fungal corneal ulcers. Right? So when we talk about bacterial and fungal corneal ulcer, the first thing that we have to know is what are the symptoms? What does a patient with this condition present to us with? So if you look at it, if we just close our eyes for a minute and think that if a patient has a bacterial infection of the cornea, what is he going to come to me with? So the first thing that we think of is he obviously is going to come to me with pain. So the main complaint is pain, redness of the eyes and lacrimation. What is lacrimation? Lacrimation means excessive watering. Then photophobia. Photophobia means intolerance to light. He is not able to open his eyes nicely if light is thrown on him. That means he is not going to be very cooperative when we try to examine him on the slit lamp. Then of course, the cornea, we know it is the main refractive structure, right? It is the most important refractive medium of the eye. So anything which affects the cornea is going to affect the vision. So decrease in vision. So these are the main complaints of the patient. But the decrease in vision comes much later here. Why? Because mainly the patient is troubled by the pain and the redness and watering and the fact that he's not able to open his eyes properly. So that is what troubles him more. So pain, redness, lacrimation, photophobia and decrease in vision. These are the symptoms. Now one very important thing here is if we ask a pointed question, they might tell us that there is a history of trauma with vegetative matter. Now, who are the people who experience this? The people who experience this are commonly the farmers, especially in the harvest season. That is, at the time when they cut their crops. So when they cut their crops, at that time they sometimes suffer this trauma with vegetative matter. And this often predisposes to the formation of fungal corneal ulcer. So that's why this is important. So in the question, if trauma with vegetative matter is mentioned, then it is more likely that they are talking about a fungal corneal ulcer. So these are the symptoms. Now let's come to the signs. I will first discuss the symptoms and signs of bacterial corneal ulcer. So in a bacterial corneal ulcer, the symptoms, they tend to be more pronounced. The symptoms are more pronounced in a bacterial corneal ulcer and they are less pronounced in a fungal corneal ulcer. Now, when you look at the ulcer, a bacterial corneal ulcer is usually a single ulcer with well-defined and distinct margins. So let's have a look at this picture. See, it's a very, very red eye. So there is lot of congestion. And where is the ulcer? See this white thing that you see, this is the ulcer. So see, there is a single ulcer. There is a single lesion or a single ulcer, single lesion. There is a single lesion, and if I were to finally mark out the margin of this lesion, see, look at the margin, it's very, very sharp. So we have sharp margins, or we can say that the margins are well defined. So sharp or well defined margins, that is, you are easily able to understand where the normal cornea ends and where this infiltrate begins. So the eye is congested, the patient is the symptoms are more pronounced. You have a single lesion, and the margins of that lesion are very sharp or well defined. Okay. Now the next thing is, the next point pertains to something which is called as a hypopion. Now what do we mean by the word hypopion? Hypopion means pus in the anterior chamber. Pus in the anterior chamber is called as hypopion. Now, it's not necessary that all corneal ulcers will have hypopion. Hypopion may be there, hypopion may not be there. Right? Now, when I talk about a hypopion, in case of a bacterial ulcer, it is not a very dense or thick hypopion. So, this hypopion is often mobile. What do I mean by mobile? It means that if you move the head, then that pus also moves along with gravity. The pus moves with gravity. Right? And also, if I were to aspirate that pus, then I would find that it is sterile, meaning it contains only pus cells or neutrophils. So the hypopion is sterile, means it contains only pus cells or neutrophils. It does not contain any bacteria, meaning the bacteria do not penetrate through the cornea into the anterior chamber. So the hypopion, if it is present, is mobile and it is sterile. Right? So if I recapitulate this once more, the symptoms tend to be more pronounced. The eye is congested or red. The ulcer is usually a single ulcer with sharp, well-defined margins. And hypopion, if present, is mobile, and if aspirated, is found to be sterile, containing only pus cells. Right? So from this clinical picture, if we make a provisional diagnosis of bacterial corneal ulcer, then how do you confirm it? We confirm it by corneal scraping. So you scrape the ulcer, and if you suspect it is bacterial, you will obviously ask for gram stain, and if you want a culture, you will ask for culture in blood agar to find out the organism. Right? So gram stain and culture in blood agar. This is for confirmation of your diagnosis. Now, what is the treatment? Treatment obviously is antibiotic eye drops. But the difference is that normally the antibiotic eye drops that we use, they are 0.3% or 0.5%. This is the usual concentration of antibiotic eye drops which is available in the market. But this concentration of antibiotic eye drops is not enough to treat a corneal ulcer. So here you need antibiotic eye drops under high concentration, and the name given to that is fortified antibiotics. So fortified antibiotics means antibiotic eye drops under high concentration. And what is the antibiotic used? The one that is used is ceftazidime, commonly 5%. So see, commonly I told you it's 0.5, here we are using 5% because this is broad spectrum. So ceftazidime 5% is the fortified antibiotic eye drops that is generally used for bacterial corneal ulcer. And along with that, we also use atropine eye drops. Now, why atropine eye drops? What is the use? Atropine is a cycloplegic. It's a cycloplegic. It relieves the spasm of the ciliary body and it helps to decrease the pain. So basically, in this milieu of a keratitis, the nerves get irritated and there is a spasm of the ciliary body which is mainly responsible for the pain. So this atropine, which is a cycloplegic, it relieves the spasm of the ciliary body and it decreases the pain. So definitive treatment is obviously ceftazidime 5%, that is fortified antibiotic eye drops, and atropine eye drops is the adjuvant which helps to relieve the pain. Okay, so this is about bacterial corneal ulcer. On the same lines, I will take you to the next one, that is a fungal corneal ulcer. Now, what about a fungal corneal ulcer? See, just like in bacterial corneal ulcer, I told you that the symptoms are more pronounced than the signs. In fungal ulcer, it is exactly the opposite. The symptoms, they tend to be less pronounced than the signs. The signs are much more than the symptoms. The symptoms are less pronounced than the signs. Now, when you look at the eye, you might see that there is a single lesion, but more commonly, you will have multiple lesions. So, what does it look like? Generally, there is one large ulcer, and there may be smaller ulcers beside this main ulcer. And these lesions, they are called as satellite lesions. But mind you, it is not necessary that fungal ulcers will always be multiple. No, it's not necessary. It can be a single ulcer also. It can be single or it may be multiple, where you have this concept of satellite lesions, where you have one large ulcer which is surrounded by multiple small ulcers, which are called as your satellite. Now, if you look at the surface of the ulcer, it is typically described as dry or leathery. So these are the key words that you have to remember. So the surface is described as dry and leathery, and the margins of the ulcer, they are ill-defined, indistinct, feathery or fuzzy. So have a look at this picture. Look at this. This is your ulcer. This is a single lesion, but look at the margins. The margins are like this, right? So they are feathery margins. If I were to work out the margins, see, these are the margins. They are like protruding into the surrounding cornea. And here also, if you look at the margins are ill-defined or fuzzy. So fuzzy margin, ill-defined margins, indistinct margins, these are the features of a fungal corneal ulcer. So it may either be a single ulcer with fuzzy, ill-defined margins, or you might have multiple ulcers, that is one large ulcer with smaller ulcers or satellite lesions. Right? All these are slit lamp photographs. These are examined on the slit lamp. These are all pictures from the slit lamp. You cannot see so many features just by putting torchlight. Now the next feature here also, it pertains to the hypopion, that is the pus. Now as I told you, it is not necessary that all ulcers will have hypopion. Like for example in this picture, see this thing, this is your hypopion. This is the hypopion. But all ulcers may or may not have hypopion. Here also we are able to see that there is a small hypopion. Now for a fungal corneal ulcer, the hypopion, it tends to be very thick, and therefore it is immobile or fixed. Now what do I mean by saying it's immobile or fixed? It means that when I tilt my head, this pus is not going to move with gravity. It will stay like this only. So even if I tilt my head, it is not going to move. And if you get a chance to aspirate that pus, you will find that it is non-sterile. Now, what do I mean by this non-sterile? It means that the fungal hyphae, they have perforated the cornea and they have entered into the anterior chamber, which is not the case with a bacterial corneal ulcer. In a bacterial corneal ulcer, it is sterile. The pus contains only neutrophils, does not contain any bacteria, but here it will contain the fungal hyphae. So if I were to summarize all the points that I told you, in a fungal corneal ulcer, the symptoms tend to be less pronounced than the signs. The lesion may be a single lesion or there may be multiple lesions. If there are multiple lesions, usually there is one large lesion with smaller lesions at the sides, which are called as satellite lesions. The margins are typically described as fuzzy or feathery or ill-defined. The surface of the ulcer is dry or leathery. And the hypopion, if present, it is fixed or immobile. And if you get a chance to aspirate it, it is non-sterile. That is, you will see the presence of fungal hyphae. Now, with these features, we get a diagnosis of a fungal ulcer provisionally. Now, how will I confirm? Obviously, here also I will confirm by doing a corneal scraping. So, how do I scrape it with a blade, and then I will ask for a QH mount, and I may ask for a culture in SDA if I want, that is Sabouraud's dextrose agar. Now, what is the treatment? Common sense says that obviously antifungal eye drops is the treatment. So, what are the antifungal eye drops that we commonly give? We commonly give natamycin 5% eye drops, or we give voriconazole, which comes as a 1% eye drops. natamycin 5% eye drops or voriconazole 1% eye drops. Now, commonly natamycin is used in India. This comes as MCQ. Why? Because most common organism causing fungal ulcer in India is Aspergillus. And Aspergillus is sensitive to natamycin. So, we in our country, we start off the treatment with natamycin 5% because most of our ulcers are caused by Aspergillus. Right? And what is the adjuvant? The adjuvant, as always, is atropine eye drops because they act as a cycloplegic and they help to relieve the pain. Okay, and what is the drug, if I ask you, which is never to be given in bacterial or fungal corneal ulcers? Will any one of you be able to tell me what is the drug that we should never give in bacterial or fungal corneal ulcers? The drug that we should never give is obviously steroids. So steroid eye drops are completely contraindicated in these two conditions. Right? So now see, I have told you what are the key words that we have to look for in the question. And I have also told you how to identify it with the help of an image. Now let me go back to the question that we had started. So see, the question says that a patient presents with pain, redness and watering. There is a large dry necrotic ulcer with feathery margins. There are two smaller lesions beside the main ulcer. So what does this mean, smaller lesions beside the main ulcer? It means obviously satellite lesions, right? It obviously means satellite lesions. So this gives us a diagnosis of fungal corneal ulcer. So see, if they say that if the question says a patient presents with pain and redness following trauma with vegetative matter. On examination, there is a large ulcer with feathery margins and two smaller lesions beside the main ulcer. As this question is saying, the answer is fungal ulcer. But if the question says that a patient presents with pain, redness and watering, on examination, there is a single ulcer with sharp margins and a mobile hypopyon. Then our answer, then obviously we have to mark bacterial ulcer as well. Right, so this is how these questions come. So these keywords, as I told you, are the ones we have to memorize. Like single ulcer, well-defined margins, sterile and mobile hypopyon for bacterial corneal ulcer. For fungal ulcer, dry and leathery surface, satellite lesions, fuzzy or feathery margins, fixed and non-sterile hypopyon. Right? So this is about fungal and bacterial corneal ulcers. Now let's come to what are the possible complications of these ulcers. Now these ulcers, they cause thinning and bulging of the cornea. So the superficial, the epithelium, the stroma gets necrosed, but the descemetes, which is the toughest layer of the cornea, that generally holds through. And because of the intraocular pressure, what happens is that the descemetes, it protrudes forward. And these protruding descemetes, this is called as a descemetocele. So thinning and bulging of the cornea, that is called as descemetocele. So what do you do about this? Now here we have to give some structural support to the cornea and you have to allow it to heal. So you put a bandage contact lens over cyanoacrylate glue. So that cyanoacrylate glue, it provides the support, and on top of this we give this tectonic support in the form of a bandage contact lens. This is to prevent the perforation of the cornea. Otherwise the cornea will perforate. Right? Now, as I said, if you don't treat the descemetocele, then at a certain point, the descemetes will also give away and the cornea will just rupture, and that's called as perforation. Now, if you have a perforation, what will you do? You will obviously have to replace the entire cornea. That is called as penetrating keratoplasty, which is a type of full thickness keratoplasty where the entire corneal tissue, that is from the epithelium to the endothelium, we replace it. So that is cornea transplantation. Penetrating keratoplasty, also called as, in common words, it is called as cornea transplantation. Right, now this is what happens in extreme cases when the patient is not responding to the therapy, that is the stroma necrosis, the descemetes bulges, perforates, etc. But suppose the patient is responding well to therapy and he's actually healing, then also when the ulcer heals, the cornea is going to become opaque. Now, why do you think that the cornea is likely to become opaque? The cornea is going to become opaque because when it heals, there is a formation of a scar, and the regular arrangement of the stromal fibers in the stroma, that is lost. Now, if you remember, the regular arrangement of the stromal fibers, they are responsible for corneal transparency. Now, when this scarring occurs, this goes and the cornea becomes opaque. So corneal opacity is, it is even when there is healing, the cornea will still lose its transparency. Right? Now, the last complication is an anterior staphyloma. Now, when will you get an anterior staphyloma? See, when the cornea perforates, then on top of it, a pseudocornea is formed, which is like a collection of exudates, fibrous tissue, and the overgrowing epithelium. Now, this false or pseudocornea with the iris tissue incarcerated behind it, all these they bulge forward, and that is called as anterior staphyloma. So these are the possible complications. So desmetocele formation, perforation, anterior staphyloma. And even if it heals, then also the patient is going to end up with a corneal. Okay, so these are the complications of corneal ulcer. So as I told you right at the beginning of this session, this is one of the topics which is like very, very favorite with all examiners. Whether you are preparing for FMG exam or you are preparing for INI-CT or you are preparing for NEET PG, this is something that irrespective of the exam, this is an important topic for everyone. So you can get questions like you can get regular questions like case scenario based questions. You can get images, that is 2 images may be given and you may be asked like whether this is a bacterial ulcer or a fungal ulcer. So as I told you, you have to look at whether it is single, what are the margins like, and then you have to make your judgment, right? And also we get questions on the complications of corneal ulcer. So I hope that this short session was useful for you. And as I told you right at the beginning of the session, if you're still not a part of our Plus platform, you can use my code Dr Sudha to enroll for the Plus subscription. And these are the different Plus subscriptions that are available to you. Right? And also I would urge you to become a part of download the app and start watching our special classes, and also to join my community where I keep putting up updates about the different special classes that I take. So apart from the classes on YouTube, you can also start watching our special classes on the app. So thank you very much everyone for being a part of this session, and hope to see you in our other sessions also. Bye bye.